So I think we'll start now. I don't see any more people joining. I'd like to introduce Professor John Massie, who's the Clinical Director of the Children's Bioethics Centre and a Senior Consultant in the Department of Respiratory and Sleep Medicine at the Royal Children's Hospital, Melbourne. John, at the CBC, he provides clinical leadership, liaison with clinical staff, ethics advice, executive, and supports the Children Bioethics Centre, building capacity in bioethics across the campus. He has published a number of books and book chapters around ethical issues and has a particular interest in decision-making with children. And he recently co-authored a great book called Deciding with Children and Healthcare. So we're very honoured that John can be with us today here in Trinity, and we're very much looking forward to your talk, John.
Thank you very much, Imelda. And despite what you might see, I'm actually here in Trinity, not in Melbourne. And it's a great privilege, and I've really enjoyed this morning walking around the campus and soaking up 600 years of history for this. And so this is something that I've been thinking about a lot and working with my group. And as a clinical ethicist, I've been in many ethics consultations. Often they come from a place of disagreement between parents and clinicians. And at the end of a long and torrid debate, someone will finally say, and what does the kid think? And of course, we all stop and realize that all the noise in the room has been taken up by the parents and by the clinician, and that the child's perspective and perhaps the child's ideas for deciding what should happen have been ignored. So I've found this a really interesting and challenging idea. I hope it floats for you as well. And mostly what I'll do today is share the ethical framework around which we've built this idea of deciding with children. So I am a clinician, a respiratory physician, done a lot of work in cystic fibrosis back in the older days when there was a lot of death and dying, and then more recently done a lot of work with home ventilation. So in both those areas, there's a lot of decision-making that goes on for children, but also a lot of decision-making that goes on with children. So in some ways, this is sort of a book tour. And I just wanted to introduce you to our book, Deciding with Children. The book has a really interesting methodology and setup. So it starts with the ethical underpinning of deciding with children. And the first author there is Georgina Hall, but with David Archard. I'm not sure if you consider David an Irishman. He's in Northern Ireland in Belfast, so he might be an Irishman. We then look at the neurocognitive aspects of deciding with children. And then with Lorraine Swords, we think about the psychosocial context in which children might be able to make decisions. Then with Imelda, we're thinking about what we know about what children want and how we should hear from children in involving them in their clinical care and in making decisions. We then think about how currently deciding about deciding about children's healthcare happens, and then develop our model of deciding with children. And then with Dominic Wilkinson in the next chapter, we think about how we might push back against that and what are the limits of deciding with children. So that's the ethical theory that goes with the book. And then there's a series of clinical chapters. And these are scenarios that we've developed, which clinicians at Royal Children's have responded to, and then a whole group of children's clinical ethicists responding to the clinician, responding to the scenario. So those are real life, in a sense, although the situations are hypothetical, they develop from real cases, situations where deciding with children might happen. So the book is out. It's a fantastic book, and really appreciate the contribution of Laurie and Imelda to the book. But before I go further, just a quick declaration. My trip is supported by my continuing medical education as part of my job, and I haven't received any royalties from the book. Maybe I will. I'm an Anglo-Australian. I grew up with a Church of England tradition. I'm a member of the Humanist Society of Victoria. I'm the husband of one and father of 3 young adults, and I'm always trying to probe them about how medical decision-making went in our household. And in case it's important, Tigger is my hero. So this is us at the Royal Children's Hospital in Melbourne, set in a lovely park with a very large cathedral-like space. And I think you're all looking forward to your new children's hospital opening. We do actually have a meerkat enclosure in the hospital run by the zoo, and I think they're very inquisitive creatures, and maybe that's a really important virtue for people working in the hospital. As is traditional in Australia, when we give talks, we like to acknowledge the traditional owners on the land in which the talk is given. Now, I'm not on traditional lands today, but the work was prepared on the lands of the Wurundjeri people of the Kulin Nation, and so I think it's still important to pay respects to their elders past, present, and emerging. Thought I'd just tell you a little bit about the Children's Bioethics Centre. Although we're a department in the hospital, we're actually funded by the Children's Hospital Foundation, a philanthropic organisation, and we provide a clinical ethics service, but it's not just a dry and dusty clinical ethics committee. We also work across the hospital with capacity building through education and our annual conference. It's just been held. It's the first week of September. And we also support the leadership of the hospital with clinical ethics, and as well as engaging research and publications. This is a group, just to put a few names to faces. So on the right of me, sitting down, is Lynn Gillam, who's a very, very well-known clinical ethicist in our community and around the world. Behind her is Sharon Feldman, who's a new generation of clinical ethicists. She has a legal background. In the middle is Georgina Hall, who was one of the co-editors. Georgina has a background in moral philosophy, but also journalism. And next to her is Jenny O'Neill, who also wrote one of the chapters. And Jenny is a clinical nurse consultant in bioethics. So she's been doing amazing work with the nursing staff at the Royal Children's Hospital, bringing ethics to them and them bringing ethics to us through her. So it's really a fantastic group of people to be working with, and all of which have co-authored chapters in the book and been there with many discussions about our idea of deciding with children. And then just briefly, this is a chart that just monitors our workload and the things that we've been doing in the hospital, and gradually building trust and respect of clinicians, so that we have now, this year we'll end up with 100 clinical consultations. We also do many education sessions for departments and ward and team support, which we frame as ethics debrief. So we're doing a lot of work with the 5 of us there. Now, as we start to think about deciding with children, we'll see some cartoons. The Book of Kells, It's Not. And these cartoons were drawn by a dear old colleague of mine, Henry Killam, who also started the clinical ethics service in Sydney and was prepared to lampoon anything, and quite often me. You can't see me, but I am 6'5", so I am rather tall. And this is one of his ideas of what deciding with children might be, which looks like me, at least trying to get to the children's level or the child's level and tell them about their thoracotomy. But I think we can do a bit better than that. So how might we consider deciding with children? And this is a very influential paper that's really worth a read, and lined from it by Navin and Wasserman in the Hastings Centre. So deciding with children is a moral ideal related to children's participation in healthcare decision-making that involves the cultivation of the child patient's awareness, understanding, and meaningful agreement with treatment. So perhaps we can anchor this in a case, and perhaps you can just think about the cases we go through deciding with children and the ethical background for that. So this is a case of vaccination for influenza against parents' wishes. So a fairly simple scenario of Jenny, 13-year-old girl in grade 7, so that's first year of high school for us, healthy person, at normal development, intelligent. Her parents do not want her vaccinated for influenza. Jenny's a keen sports person. She doesn't want to get influenza and miss training and competition. So how should we approach this? So this is how decision-making with children has gone and is still published and discussed in these terms. So this is from Paediatrics, American Journal. This is in 2017, but there are similar publications from as recently as 2024, where there's a decision for a child that somehow is shared between a physician or the family in some sort of shared decision-making arrangement, and the proportion of that might weight more with the physician or more with the family. But as you can see, the problem here is really that there is no clear role for the child. So it's all about the physician's role, about the family's role. And it's very strongly based on what is a wonderful book by Buchanan and Brock, Deciding for Others. And this is the context in which decision-making in paediatrics, I think, is still practiced, and the person about whom we're making decisions is not included enough or at all in decision-making. So here is an iceberg diagram, if you can believe that that triangle is an iceberg, and the red line then is the water line on which it's floating in. So here are sort of current concepts around what might happen with decision-making. There's good sort of general paediatric practice that's based around family and child-centered care. I'm not a big fan of family-centered care because I think it's all too easy to leave the child aside in the interests of the family. Then there's essentially the decision, and that might be based on things like capacity to decide, decision-making, authority, usually with decision-making shared with parents, and then consent for a procedure. Some tools that might come into play could be Gillick competence in the Anglosphere, or mature minor in North America, how parents might consider the decision with the zone, best interests or harm principle. And somewhere along the waterline is floating an assent or dissent. But really in this model, it's all about either the child decides because they have capacity in a Gillick style or mature minor style, or the parents make decisions. And really, if the child is not able to make the decision, then they're out as a decision maker and not included. So because of this, we can be better and we can do more. And I know there's people listening who are from children's hospitals here, and I hope there are. And children are considered in general to lack capacity, in a sense, have to prove their capacity to make decisions. But decision-making doesn't have to, for children or with children, doesn't have to entirely consider capacity. We pay lip service to involving children, and particularly when children are sick or disabled, they're very, very quickly overlooked. And think particularly with children who have difficulty with communication. There's been nothing wrong with cognitive function, but just difficulty communicating are very easily left out. Parents have a role, parents have needs, but very often parents take up the decision-making space. Or, as we were alluding to on the slide before, it's a competition between the child and the parent in decision-making. And if we're considering family-centered care, then, as I've highlighted, my concerns about the child being lost in the interests of the family. So first bioethical principle that really underpins deciding with children is respect for autonomy. Now, autonomy doesn't really work for children because in a very, very strict sense, if perhaps thinking of Aristotelian ethics or Kantian ethics, there's a very, very high bar set for autonomy. But if we frame that as respect for persons, then all of a sudden things look different in paediatrics. And so here's a comment from David Archard, who, as I said before, was one of the authors of the first chapter looking at the ethical underpinning of deciding with children. And he said, listening to the child should be for intrinsic and not only for instrumental reasons. So I think if we think of respect for persons, then automatically the child needs to be considered in the decision-making process. So deciding with children respects the child as a person, but I think we need to go deeper. And it acknowledges that what happens to the child is important to the child. And then there are from that open up a whole lot of philosophical concepts and principles that further justify deciding with children. And unfortunately, I think we still are in a position where we are justifying deciding with children. So highlighted respect for persons. The decisions that are being made or are involving the children are self-regarding decisions. What happens to them is important to them. Is listening to the voice of the child, but more than just listening, is it's trying to involve the child in the decision-making process, which I think is the next level. If we don't tell the child what's going on, so this is about truth-telling, then the child is suffering from epistemic injustice. There's dignity in that respect for persons and consideration of bodily sovereignty. And if we need, we can consider where the rights of the child, particularly to have a voice in their healthcare, articulated in the United Nations Convention on the Right of the Child, Article 12. But I think that these ideas above that are what underpin those rights. Of course, there is a therapeutic benefit or an instrumental reason for deciding with children, and that is that listening to a child patient will produce better outcomes overall. Compliance with planned treatment or buy-in from the child, and better psychosocial outcomes from including preferences. So deciding with children, including them, builds trust in the therapeutic relationship and develops communication skills of young people and communication between the doctor and the patient. And then, importantly, it develops decision-making capability in the future. And I think when we start thinking about deciding with children, we are thinking of this as a process. So you notice in the first iceberg drawing, we talked about the decision. We saw that there above the waterline is the decision, whereas deciding is a process. And so, which leads to decision-making capacity for the child as they approach their majority. But I think the harm minimization or non-maleficence, if we're thinking of the bioethical principle, is also important. If we don't ask, we don't know if and how we might be overriding the preferences or decisions of the child. And one of the simple ideas for me working in cystic fibrosis, for example, for years has been, I might decide with the parents that a kid needs to come into hospital for intravenous antibiotics and chest physiotherapy. We call that a tune-up, a bit like a car. Now, we're not abandoning the decision to the child. That needs to be, that intervention of a tune-up needs to be done. But around that decision are many ways that we can involve the child. And frequently when together we're thinking about coming into hospital, having a tune-up, and the child often starts crying, one might think, well, okay, we not unreasonably expect that you're going to have to come in, you're going to have an IV, you're going to have blood tests, you're going to be away from your family and school and staying in the hospital. But actually, frequently what distresses the kid is that they're missing out on something. And so often what's behind the tears is something like it's the basketball final next week, or Jimmy's having his birthday, and that's not a good time to be in hospital. So if we're not involving the child, and it may not be all about whether to come into hospital or not, but it may be about whether to come into hospital now or next week or the following week, if that's clinically appropriate, we can allow the child to be involved in decision-making. We can ask them and not just trash their preferences or the values or what's important to them. And while this might be a small part of the decision, I think it's still part of deciding with children and start of us trying to find ways that we can include the child in the decision-making, and hopefully older on, hopefully as the child gets older, then later on they can actually actively be in that decision-making space for deciding to come into hospital at the recommendation of their clinician and or support from their parents. So there are some other bioethical concepts of deciding with children that are really important. And one of those is truth-telling. And if we don't tell the kids what's going on, how can they decide? And I think we see this as a huge issue in the oncology service. Kids come in, parents don't necessarily want to tell the child they've got a cancer. That makes it really hard to engage the child in the treatment processes, and then can't involve them in the treatment processes that involving them in decision-making about the treatment is just not there at all. So truth-telling is really important. And of course, that's underpinned by respect for the child as a person, or respect for autonomy, if you want to peg it back to one of the 4 principles. Increasingly, privacy becomes an issue, and we get to our model of deciding with children, we'll see that privacy becomes a very important consideration. So there are things that children just don't want or need their parents to know, but are really important in this space about decision-making. And then we want to think about the interests of children, and children have all sorts of interests. And so this is a paper from Claire Delaney, who's also been in our group, and has written this wonderful paper called The Cluster of Children's Interests. And kids have all sorts of wide-ranging interests beyond just their healthcare. But if we're thinking about healthcare and we're thinking about decision-making, then particularly across that middle set of circles, then there's all sorts of things that deciding with children can do. So we can think of bringing out their expression of their preferences and values and ability to communicate those, which may need to be coached, taught, learnt. I think that deciding with children promotes a sense of self, and across from that is the sense of control in terms of what's going on. And it may even boost the parental relationship. So deciding with children fits very much across what are in the interests of children and young people. Now, it's important to try and think about what children want. I have apologized to Imelda already for this slide. So I prepared the slide. I've put a couple of references there, and I think these are possibly the only 2 references in this field that Imelda didn't actually write or do the research for. But what's clear from Imelda's research and from others is that children want direct communication. So that does involve truth-telling. And they want a shared or active participation in decision-making. So this is in Imelda's chapter of the book, and I hope you can get access to the book either directly through purchasing it, but particularly perhaps through your library there, because this is one slide of an area that has enormous depth and complexities. So the next thing as we're thinking about deciding with children is just thinking about shared decision-making. And of course, shared decision-making is accepted as the way that healthcare decisions are made. Colleagues in adult medicine practice are very familiar of the clinician and the patient talking and coming to an arrangement, and perhaps that includes an arrangement of how much of the decision the clinician might take on, how much the patient wants to take on. But it gets infinitely more complicated when there's a child involved, and child's not just a third party, the child is the party. This is decision-making about the child. that both but all three, the child, the clinician, and the parent have interests in. And I think, as we've seen, it can unravel so that the child is left out of decision-making. So how might shared decision-making be conceptualized? So let's accept that there's actually quite a lot of argument about exactly what shared decision-making is. But this paper by Charles covers 4 stages of shared decision-making in adult practice, so that there are at least 2 participants, that there's information sharing, that both parties participate in decision-making, and then an agreement is reached. So for shared decision-making with children, that is really deciding with children, one of the participants is going to be a child, that they're given the opportunity to be involved and that they're willing to be involved. So I think one of the very, very easy tropes here against deciding with children is that we might be abandoning the child to the decision, or leaving too much to the child, resting too many big things on their shoulders. And that's not the idea at all. So the child should be willing to be involved. And I hope as the children get older, that willingness can be brought out. I find it personally particularly troubling when I'm doing transition to adult service clinics and parents are still the main voice, and a child is either choosing to allow their parents to be the main voice, or perhaps worse still, silenced by their parents still. So I think we do need to assess willingness, but then we also need to bring the child out to be involved in the decision-making process the older they get and the nearer to transition to adult services. Information, of course, needs to be shared in an age-appropriate way, and we'd like the child to make a contribution to decision-making directly, so not through their parents' interpretation of their preferences or values or best interests, but actively trying to find out the child's preferences and values. And we may not always be able to agree with the child, but as we highlighted before, under that bioethical principle of non-maleficence, if we don't ask, we risk trashing their preferences and values and not having the opportunity even to apologise. So then shared decision-making with children could look like a number of things. It might be that the child is able to consent, like Gillick competence or mature minor, and in this, the child is accepting responsibility for the outcome. I think there's still a lot of work to be done and thought about in this idea of accepting responsibility. So it's one thing to make a decision, another to accept, well, what happens if things go wrong? But that's what underpins consent and perhaps Gillick competence with that. Next might be, well, it's not Gillick competence, but we're looking for some agreement with the child. So it might be as much as consent, but not legally recognised, and the child and parent are sharing responsibility for the outcome. And one of the ways that we might do this practically is by sharing the consent form. So getting the child to sign a consent form if it's for a procedure, and also the parents signing the consent form. Another type then of decision might end in assent, where the parent accepts the responsibility for the outcome and the child agrees with the process. Or it might be that the child dissents and doesn't agree, but the reasons are explained and dissent is responded to appropriately. So if we don't ask, we don't know, and we don't have the opportunity to apologise to the child. So here the parent, perhaps a clinician, are accepting responsibility for the outcome. If it's something serious, the procedure needs to go ahead. But perhaps there are other situations where child's dissent needs to be honoured as well. And so I think there's also very careful about how we ask those questions when we're seeking for agreement or assent in procedures. So deciding is complicated. And so someone needs to be able to formulate a preference and understand the facts. But in the book, we'll see that even really young children are able to articulate a preference. So in the example in the book, there's a young one who needs, she was 3, she needs an IV. Mum doesn't want to be involved. She doesn't want to see a child distressed by the IV and wants to leave. The child is distressed not by the prospect of the IV as much, but by the prospect of mum leaving, and so is able to voice that. And so if we're open to deciding with children, perhaps we can consider that as a preference and that as part of the decision-making process, that the child wants mum to be there. Child may be offered something along the lines of left hand or right hand. Child may be offered different types of analgesia for a procedure. Child may be offered a red cast or a blue cast, and Jimmy might choose a red or a pink cast and have a discussion with mum and dad that his clothes are blue and his room's painted blue, and perhaps that's not in line with his preferences. But perhaps that doesn't matter if he still chooses a pink cast, and perhaps the consequences that he wants to change it another day but can't. And there's a learning opportunity, but there's also an opportunity there to try and peg that decision to his preferences and values. So values and goals help determine which path might be. And then you have to actually make the decision to articulate a preference, to act on the preference, and to take responsibility. So I think these are setting the bar pretty high. But I think if we think of deciding with children as a process, we can try and find ways to draw even the young children into the decision-making space and find out what their preferences might be. So what's important is that you are caring about something in a particular way, and the goals or values are your own and that they're authentic. Maybe they're sensible, rational, ideally stable and enduring, not a whim, and reflects some settled self and not just emotional responses. And sometimes decision-making needs prioritizing, identifying what you care about most. So pulling these together, then I want to just expand on the iceberg a little bit. So here we have changed things, although the structure looks fairly similar, that we have good paediatric practice at the bottom, but that the decision isn't everything, and that perhaps it's deciding with children that is. And that's where we get in the middle section here, just below assent, that then these ideas that we need to create spaces for decision-making with the child. And I think it's the job of the paediatrician, particularly because parents are often taking up the oxygen in the room and taking the space. We need to consider willingness to participate. We want to share and elicit information in an age-appropriate manner. And then we want to try and elicit preferences and values and help weigh up options and ideas and align those to the preferences and values. And then we may end up with assent, or ideally we may perhaps even consent there. And that there are some tools that we're using when we're doing that, which are scaffolding autonomy and supporting decision-making. And that we want to see deciding with children as a process. So it's happening here below the waterline of a decision and is building on good paediatric practice. So if we think that decision-making in paediatrics has principally been between parents and clinician, we want to introduce the child into the equation. So we move from a pas de deux to a pas de trois, and decision-making can be a careful dance, which is an expression that John Lantos, a well-known bioethicist, talks about. So here's our model. This model that is roughly in 4 stages. It's not pegged against any particular age. People have tried to say there's a rule of 7s, under 7s. Parents decide 7 to 14. It's together and over 14. It's the child. But I really think that's just too simplistic. And there are many considerations which take into account the age and capacity, take into account the nature of the decision. We can see that privacy is there on one of the x-axes too. So early on with an infant, the decision-making will be principally the clinician and parents. But as we started to say, maybe we can see some preferences an infant or young child might be able to make. As the child gets older and has greater capacity, then the child should come into the decision-making sphere. Remembering what happens to the child is important to the child, and it's important for the child to feel valued. The next stage is having clinician, child, and parents together making a decision. So that might be an agreement model, if you like. And then in the final stage, it's really between the clinician and young person, with the parent more on the sidelines, perhaps providing some of the scaffolding to decision-making. And remember, just because we cross that line of majority over 18, and although legally then the child is no longer a child, is an adult and is assumed to have capacity, and we have to prove non-capacity, you can see that very few of us would actually be making big decisions without some of our family or loved ones involved. But that's what we're trying to head for, deciding with children, is developing an independent decision maker. So this takes into account developmental stage, willingness to participate, lived experience of the disease. And this is an important point that Laurie makes in her chapter about the psychosocial milieu in which decisions are made, particularly children with chronic illnesses who may have far greater capacity to make decisions than others. They're perhaps prematurely mature. They know what the disease is. They have a great understanding. And so they may need and should be given greater role in decision making. And of course, it does take into account the nature of the decision. And that's always been an important concept and does also underpin Gillick. But it's not dependent on capacity. So children can still be involved even if they don't have capacity to take full responsibility for the decision. It's not dependent on the somewhat slippery concept of autonomy in children, but it is dependent on respect for children. And importantly, we're not ceding decisional responsibility or authority to children. So children can be involved without having the final say by asking their opinion and their preferences and finding out what matters to them. And as we were highlighting before, that might be that basketball really matters to them, and Jimmy's in the finals and he wants to play finals, and we can delay his admission to hospital. We want to tell kids that they have an important role to play in their healthcare, and what happens to them is important, and that adults care what they think, and that we can assess their understanding of decisions or parts of those decisions. So it's not an all or nothing dichotomy for decision-making with children. And then the intrinsic benefit, so that child is central to this decision, gives a locus of control, which you know is important in the child's interests, and that children feel valued. This then can help the child speak up in the future, guides the child to become an independent decision maker, and ideally improves outcomes of their health. So this is part of a triptych, but this is the part of the triptych that Henry drew, which is deciding with clinicians and how it might look, and thinking about what might the clinician's role be in healthcare, paediatric healthcare, and deciding. So we have a paediatric handbook, and I gathered a couple of comments from a couple of the chapters. So chapter 1 thinks about communication, and this is including young children, involving child in the consultation appropriate for the developmental level, and encouragement to be alert to verbal and non-verbal cues. But I'm also keen that what we're doing here is not just involving the child in healthcare, but trying to elevate their role into decision-making. And in adolescent medicine, then of course, actively engaging the child, assessing the psychosocial concerns, and supporting families to understand health and adolescent development. Of course, we know that parents might take up a lot of room and a lot of oxygen. And one of our roles as a clinician is to try and find space for the child while acknowledging the parent as the natural and legal guardian and decision maker for children. So sometimes we need to coach the parents. So we're coaching the parents, coaching the child, a bit like on the trainer wheels, running alongside, stepping back. So sometimes we need to be supporting parents being effective, skilled adults as parents. So with scaffolding a child and adolescent's potential to contribute, we help them understand the facts and options available, articulate their values and preferences, and appreciate how their values relate to the facts and which options are available. But we're prepared to override a child's preferences and values if the decision they make is going to cause significant harm. And we can do that and apologise if we need to. So here we might end up at the final arrangement, which is a far more even arrangement with the clinician, the child in the centre, and the parents supporting the child. And this is far more what our idea of deciding with children might actually be. So just a couple of final points. Do we leave the choice to the child or to not? So no young child should be made to take responsibility if they don't want to take it. That parents should step up, and there are plenty of cases we've had in our clinical ethics service where parents have found it very, very difficult to step up and have tried to leave the decision to the child, which is unfair and which for us needs a lot of coaching of the parents. But if parents are unwilling, then clinicians should step in. So this is still a model of shared decision making. So I think if you agree with us that deciding with children is a thing, then it does create obligations. So we need to collaborate with the child to participate. We need to create space with the parents to allow the child into the decision-making space. And we need to be prepared to coach the parents and the child about decision-making. So that then just brings the triptych together. And brings us back, if we want to consider how this might look for vaccination against parents' wishes in quite a young patient. And just before we have some discussion, just a little bit of promotional material. Simple version of Deciding with Children we published in Archives of Disease in Childhood. And also published a piece about vaccinating young people from the age of 12. This was for COVID against parents' wishes, for which I was accused of single-handedly ruining the Australian family, and the internet went quite nuts there, which was really very, very interesting and misunderstood. We have a podcast channel called Essential Ethics, where we discuss lots of ethical issues, including really foundational ethical concepts, classic conundrums. There's a couple of series on deciding with children, and we have summaries from our various conferences there. And of course, I'd like to welcome you to the 17th National Paediatric Bioethics Conference that the CBC hosts in Melbourne, which will be 2nd to 4th of September next year. Well, thank you, everybody. And I think Imelda might have some comments in the chat that we can respond to.
Thank you very much. That was such an interesting, a brilliant talk. So many things running through my mind as I'm listening. I did forget to mention that this was the first seminar in our series for the Trinity Research in Childhood Centre. And we are really delighted that you can be kickstart the year off with such a fantastic overview of deciding with children. I have a question, which is, you talked about creating space for children's involvement. Can you tell us a bit more how maybe clinicians could do that, like doctors and nurses and other healthcare professionals?
Sure. For me, Imelda, the very first thing that happens is when the child comes into my clinic is I sit them down next to me. So frequently the family will come in, often the adults first, child behind, parent sits next to me, and then I need to get them up and move them and sit the child down next to me and then start engaging the child. And I think that's the foundation of good, what I call in the iceberg, good paediatric practice. But then that allows me to develop my relationship with the child, puts the child at the center, not just physically, but in terms of the consultation allows me to, even from, relatively young kids will tell me what colour their asthma puffer is and whether they use a spacer or not. So automatically they're really involved, as well as, initially spending some time just getting to know them, and then the other people in the room, getting them to introduce their parents to me. So, you could even call that social skills training, but it's all really part of it. And then as the consultation goes along, including them in what happens and reframing some of the responses of the parent, for the child. Now, in the older child, of course, and that might be the middle high school child, will often be asking the parents to leave so that the young person can physically have some space and talk about things. But I think if we at least start by having the kids sitting next to us and including them in what's going on, then that's a really, really good start. And it does so much work, doesn't it? It builds the trust of the kid. It makes them feel valued, and I think brings them out to want to have a say in what goes on. So it's where, in simple terms, we get to talk about what sort of puffer you might like and how you might remember in the morning, all of which can be framed, I think, in terms of decision making, albeit small decisions that build to some bigger ones.
And what would you say to come back at clinicians who might say, I'm too busy for this, I don't have the time for this, and does it really matter to children? We need to get this done.
Yeah, I think that's a really important point, because we see that a lot. But my experience with kids is that when you try to go faster, it all ends up going slower anyway. So that would be an instrumental response, not an unimportant one. And really, the skilled paediatrician doesn't take very long to meet, to greet, to start getting some important points of history, to start including the child, even if the conversation is adult, and is always going to be better. And I think, we have an obligation to make all healthcare experiences go well. We want the kids to enjoy coming to see the doctor. In my clinic, having fun, as long as they're not funnier than me, we're okay. And so then again, that's part of, so much that's important. But I think so many adults who don't engage in healthcare is because, as a child, they've been jabbed and stabbed and teeth pulled and all sorts of things. And we can do better than that. So I don't think it takes as much time as you think. And in fact, in the longer run, ends up saving, if time's in, which it is important, but it's important to clinician, saves time.
That's great. I'm just going to pass you over to Laurie. She has a question for you.
Thanks, Imelda. Thanks, John. I really enjoyed your talk. I was wondering, could you talk a little bit more about this idea of accepting responsibility for the outcome of a decision, particularly if it's a child who's driving a preference and they want to make a decision, but the outcome isn't what was expected or hoped for? Are there ethical considerations to take into account there? How do we support children, if the outcome is not what was expected?
Yeah, that's a great question, and I don't think is entirely answered in deciding with children. I don't think is entirely answered in this whole space of decision making with or perhaps for children, because I think even in GILIC, there's a whole lot of criteria that are laid down in GILIC which talk about the ability of the young child patient to make that decision. The nature of the decision, understanding reasons for and against, side effects or complications, and then agreeing to do it. And then most of GILIC sort of works in those pro-child, pro-health situations like contraception, which was the original decision for GILIC. I think it works well in vaccination, but I think when that child patient has a DVT or has a massive local reaction from their vaccine, who's really responsible for that? And I suspect the child doesn't necessarily want to or feel responsible, and maybe that becomes something that's the clinician needs to take on or share a little bit more. But it's a very important project, isn't it, that children are drawn into the decision-making process and learn, and maybe have to make some mistakes too along the way, which aren't too big, and be prepared to accept them. And then I guess that opens up a whole nother conversation, doesn't it, about that.
I suppose it underscores the importance of the shared decision making too, or that they feel some support, that if things don't go the way that was expected, it's not all on them, you know. So you mentioned parents stepping up in certain situations.
And parents might even be saying the same thing, or adult patients and their GP or their surgeon, that things go wrong, and then that's potentially still needs to be shared. But I guess, isn't it, it's about having this dialogue with the children. It's about being to apologise when you go against their wishes. It's perhaps being able to apologise in a way when things don't go right, but all of which is part of a good communication and centering the child.
Great, thank you.
Yeah.
Thank you. I really enjoyed your session, Professor Massie, and plenty of food for thought. That's from our Chief Director of Nursing. Very informative and interesting, great webinar, great approach about empowering children and giving them a sense of control over what's happening to them. I'm just going to try and get in another question.
Can I just respond to that, though, from the Director of Nursing, because I think, you know, there's so much work, done by the nursing staff. It's why we've got a CNC in bioethics in our group, and that nurses are involved in decision making. So you may think about this as sort of medical decision making, but you know, an awful lot goes on, particularly in terms of procedures, that nursing staff can have a very, very active role in supporting kids and promoting their decision making, and being that person who can then relate both to the child and to the staff, or to the parents, or represent the child. So I'm really pleased that the Director of Nursing was here, and I still feel it's a under-recognised role in clinical ethics, is the role of the nurse as ethicist. Even everyday practice. That's why we're sort of so pleased that we're capacity building with our nursing staff. Yeah,
that's a very good point. And nurses often are the key advocate there for the child. Yeah. The child has talked to them, and they can kind of like intercede or say they have a question or whatever. So this is another big question just to ask you, John, is you know, there's a lot of people passionate about this, and a lot of great work happening, including from your centre. Why do you think progress has been slow to a certain extent in participation?
That's really interesting to reflect on. I think that it's a combination of parents as guardians and decision makers, but it's also a problem of clinicians. So in terms of the parents, they ring up and make the appointment. The messages are sent to the parents. They come in, check in. They might pay the bill before or after. They're parents who have a role to protect their children. The children's illness worries them, and they speak for the child. And so that's where it's the clinicians. So you can see easily how it just builds, and then how the kids walk in slowly, so parents walk quickly. So they're the first in the room, and they plunk themselves down on the big people's seats, and all of a sudden it's the adults talking. And then if the kid has some sort of disability and they're parked in the corner in their wheelchair, and then it's all going wrong right from the start. But then I think you highlight that I just don't think that clinicians are attuned to this as much as they should be. And perhaps it's training, perhaps it's time. And I'm really sad to say, I think that even happens in children's hospitals, that we're not good enough. And just this, for me, the whole exercise of thinking about deciding with children, I think has made me far more conscious of how I approach children in my work. I don't think I was bad at it before, but I think I'm a hell of a lot better at it now. So hopefully there's some young people listening, by which I mean people younger than me, which is most of the world now, who can just go straight to this.
Yeah. And I think about, you've given us lots of examples of how children can be involved, and it's about us all taking part and trying to promote children's participation. Just to say to people who are putting on comments that this will be recorded, is being recorded and will be shared. So you're spreading the gospel as we speak, John. And another one to say thank you very much, Professor Massie, for an informative and inspiring presentation. It's been really interesting, and I think there's work there to be done in raising awareness of the general public, and particularly parents, as you say, because if they support the child's participation, then probably makes the clinician's job that bit easier to try and include the child.
Yeah, I definitely think so. I'd be fascinated to see how much traction this might get across the Atlantic, because my suspicion is across in America, they'd spend a lot of time talking about parental authority. And it worries me tremendously that that's what's important. But of course, the child then becomes a parent, and then so then they should. Where are they going to get their decision-making skills from? If they have.
They're not expected to acquire them when they reach 18 and leave the children's services. That suddenly descends on them. They need to develop these skills well in advance. And too much emphasis on parental authority and all of that. So it is about raising awareness and trying to encourage people. And it does take less time if you involve children. Yeah.
Well, I think your work has shown that, hasn't it? And so I think this, thank you for this important, really collaboration with you and with Laurie to think about the milieu, the complicated milieu in which decisions are made. But I hope that deciding with children is sort of a riff that can cut through some of that.
Yeah. And thank you very much for including us in your book. And I think the fact that a lot of the book is worked examples of how children are involved in various clinical decisions, that's really like a handbook for professionals, because we get asked often, how should I involve a child? I really want to, but I don't know how to, and I don't know, is there any drawbacks to it? So I think your book that you've done with your colleagues will be really, really useful.
Perhaps we could call it our book, Imelda.
Yeah, probably.
Lots of us involved and lots of us passionate in the area.
Yeah, I should keep calling it ours. And just more comments saying, thank you, great presentation. We really need to reflect on how we communicate with children of all ages, especially children with additional communication needs and families with communication needs. So that's a good comment. Yeah.
Yeah, I think there's some of the most easily forgotten and the hardest there, and I think that goes beyond just language. Language. Different people from different countries with different languages, but very much people where communicating is physically difficult for them. So we do have a chapter called Beyond Disability, and how to, which is really very much the same as we're doing with everybody else, but really being super conscious of drawing the child in, of finding out how much they know and can be involved in decision making. And I think we usually get surprised by the child's response and the parent's translation if it's hard to understand the child. And it's a great joy.
I just noticed, John, that you're very sought after and you have another appointment to go to. So I'll have to draw this to a close. On behalf of the members of Trinity Research and Childhood Centre and all the people who have participated in the webinar today, thank you very much for a brilliant talk, John. and safe travels.
Thank you very much. Thank you, everybody.